Bom, boa noite a todos.
All right, good evening, everybody. Welcome to one more webinar that we're starting here. I would like to first off thank the original citeBJAN and their board for the opportunity, for their support to be able to perform this monthly webinar, Brazilian Journal. Always focusing on important scientific publications that approach several subjects that are relevant. Themes related to intensive therapy and pain management. I'd also like to remind you that this webinar is being recorded and will be made available in Portuguese and English in our YouTube channel. So once again, please share this with your colleagues that cannot watch this event live in our YouTube channel. You can find all these webinars from the start of the activity. Certainly, all the activities are quite relevant, and you can.
Nós sempre convidamos para vocês seguirem os nossos diversos canais nas mídias sociais, não só no
social media, not just on YouTube, but all the media you may have, and share the published information. Oh, I'd like to let you know that we'll be in the next Brazilian Congress on Anesthesiology will happen in Rio de Janeiro. So, yeah, speak about the magazine on the SBA stand. Ribeiro will be there to explain everything, any doubts you may have. So, to start our webinar, I would like to present our moderator for today, Mr. Luis Marcelo Wissonler. Professor, you all know him well, anesthesiologist intensivist at the clinical hospital at the University of São Paulo. He was my mentor during my residence, I'm proud to say. I learned a lot from him and our associate editor of the Brazilian Journal, on top of an extensive amount of scientific publications, international publications, contributing a lot to the magazine and publication with relevant papers. We're going to have the chance to discuss about a bit about this today. So, thank you so much, Andre, for your attentive words. I would like to thank the invitation of the publication, Andre, to moderate this discussion regarding such an important subject matter. We participate, or as I participate when it comes to treating surgical patients. So, what happens in the perioperative situation and with infectious diseases, infectious complications? And this will be led by Dr. Estevão Bassi. Dr. Estevão Bassi, he was my student during doctorate. Recently, he defended his thesis here in the medicine university for high-risk surgical patients within an urgent scenario. Without any further delays, I'd like to pass the word for Dr. Estevão to present his class. And at the end, we will go into a discussion where everyone may ask any questions they may have. Good evening, everyone. First off, I wanted to thank the invitation from the BJAN. For me, it's an honor to speak about this subject matter. I love this subject matter. I am fascinated by this subject. Have been for some time. I'd like to thank Professor Luis Marcelo, who was my orientator during my grad school. As Andre said, we are two people that are very thankful to Professor Luis and speaking about infectious diseases and perioperative scenarios. So I have no conflict of interest. I have no connections to any industry that may interfere with this presentation. So this presentation will be based on the article published on the different magazine, which is the impact of delaying the early antibiotic therapy in non-septic surgical patients with suspected nosocomial infection. It is a respective analysis. It's a long title. We'll try to see what this all means, where we're trying to go, where we were trying to go with this question and with this analysis. So a lot of authors, they argue that the antibiotic is the main advancement of medicine in the 20th century. A lot of authors defend this, and this antibiotics increased the life expectancy of humanity for a few years since they appeared. Some say 5, 7, 10 years. The fact is that for a therapy for behavior and humanity's lifespan is not a small thing, it's a big thing. And without antibiotics, surgery, as we know today, would not be possible. No transplants and no many things would not happen. And a lot of the time, antibiotics, it is an urgent behavior. I'm gonna explain that a bit more. It is a behavior that must be taken at that point in time during a short window of time. So to understand a bit more about this, there's no way for us to not talk about sepsis. So up till 1992, a few concepts were a little bit interchangeable, maybe a bit confusing, such as infection, sepsis, septicemia. Sepsis came up, the first definition that was agreed upon, it was defined very clearly that SIRS was two or more of the following: fever or hypothermia, tachycardia. Sepsis was as unchanged SIRS. Infection, serious sepsis, grave sepsis, was an organic dysfunction and septic shock, all of this with a hemodynamic shock. So we had this scenario. I don't know if you can see my mouse pointer, but the systemic inflammatory response could be trauma, surgery, burns. When there was an infection of one one of these is what two was called sepsis. When we had an acute organic dysfunction will be acute sepsis or septic shock. And with this, there was a huge leap when it came to scientific research when it comes to acute infections. One of the more impactful papers was this one from Cooper, was published in 2006. It showed that for every hour delayed when it comes to applying antibiotics during septic shock was an increase in mortality rate, 7%. So for every hour of delay, a patient would do worse. So we came up with guidelines, which is the survival sepsis guidelines. Also in the first editions, where he talked about antibiotics during septic shock must be administered during the first hour when it is recognized as happening. So afterwards, definitions move forward, 92, sepsis 1.0, 2003, sepsis 2.0. That didn't really change much from 1.0. There was no big evolution. And now, well, actually some time now, sepsis 3.0, which actually proposed to change the definition. Sepsis 3.0 defines sepsis as an infection associated to organic dysfunction and define organic dysfunction as SOFA or a quick SOFA. We're going to go further in depth there. Septic shock did not change the definition a lot, but there was a need for hyperlipidemia, so hypotension, then there's thing for vasopressor and interleukitemia. So why does this group of authors, why do they prefer SOFA and SIRS? Well, it's actually quite simple when it comes to the choice. Whether it's right or wrong, their argument is quite clear. Because of a higher level accuracy of seeing outcomes, of foreseeing outcomes. You can see the SIRS in this chart had a rock curve of 0.64 and a SOFA 0.74. It's considered to be better, so that's the reason why. Here, to remember the SOFA scale, it has 6 dimensions. It quantifies organic dysfunction in each dimension from 0 to 4, and we add this up and we obtain the final score. Going back to the impact of the timing of the antibiotic therapy during septic shock in this New York study, also observational study as the one for Cooper and Kumar, it had 40,000 patients in 49,849 hospitals. Enforced that concept where every hour of delay when it comes to applying antibiotics during septic shock and sepsis, there will be a worse prognosis associated with this observationally as well. We need to note that this study or others, they did not get to that mathematical formula of 7%. A lot of folks think that that is a bit of an exaggeration, but we came to the concept of delaying antibiotic application and sepsis and septic shock. It is not a good thing. So this effect seems to be more noticeable or much more noticeable when it comes to patients using vasopressors. So septic shock here, you can see the sub-analysis, you can see during septic shock, this relation is more clear. So we have this following scenario. We have the systemic inflammatory response, we have the bacterial infection, which requires antibiotics, and then we have sepsis, which is when we have an organic dysfunction. During sepsis, antibiotics gain an urgent character. So up till now, I think that it is quite clear, but we went back to the initial slide. Antibiotics is an advancement, a huge leap forward in 20th century medicine. It increased life expectancy for humanity. However, we're seeing a few issues. We're facing a few issues. Well, multi-resistant bacterial blooms are multiply. So there's a bit of an anecdote. KBC bacteria on the Rio de Janeiro beaches, superbacteria's close ICUs, they stop surgeries and they cause very serious infections with mortality above 50% sometimes. We are facing today a serious problem regarding the use of antibiotics, which is the appearance of bacterial resistance to antibiotics. So we have an idea here in the Americas. This study gives us as a worldwide panorama for resistances. We can see in the Americas, about 20% of E. coli are resistant to ceftriaxone as a third generation antibiotic. When we pick up pneumonia, the resistance to cephalosporin of third generation cephalosporin can reach 50%. So the use of large-scale antibiotics brought consequences when it comes to bacterial resistance in the community, but also has consequences from the individual point of view. This Lancet study calculated the number of yearly deaths associated to the presence of resistant bacteria and attributed to resistant bacteria. You can see that it is associated here. This LRI plus is the infection of the lower respiratory tract. More than 1.5 million people die from just lower respiratory tract infection associated with bacteria. When we went to the attribution, when we added up 500,000, almost 500,000 in the lower respiratory tract. When we add this up, it's a huge amount of people. So what I'm saying is that bacteria that are resistant
do ponto de vista individual, podendo causar morbidade para o paciente. Além disso, tem os efeitos colaterais dos antibióticos. Esse estudo estimou que 20% dos pacientes que usam antibiótico internados têm algum efeito colateral, seja Clostridium, seja insuficiência renal. Falando em insuficiência renal, a nefrite intersticial aguda é mais comum do que a gente pensa. Até 27% das biópsias em insuficiência renal aguda. E a principal causa é antibiótico. Indo para um outro problema, né, relacionado. O uso do antibiótico no último mês dá um risco ao paciente de ter bactérias multiresistentes e colonizados 5 vezes maior, 5,32, do que quem não usou. E muitas vezes se pensa que essa colonização dura algumas semanas e passa. Mas esse estudo, por exemplo, de Chicago, mostrou uma colonização com tempo médio de 9 meses depois que o paciente adquire uma KPC. Então, muitas vezes o paciente é colonizado por longo tempo e mais suscetível à infecção. Por exemplo, esse estudo mostrou que os pacientes que receberam antimicrobiano de amplo espectro tinham 1,65 mais chance, mais risco de desenvolver nova sepse e choque séptico. A explicação varia, mas envolve alteração da microbiota intestinal, disfunção mitocondrial, disfunção de leucócito, dentre outros. Então, como é que a gente equilibra essa balança, né? O antibiótico é uma aquisição maravilhosa da medicina, que modificou a história da grande parte das doenças. A gente precisa dar antibiótico em caráter de urgência, muitas vezes, porém, a gente não é uma terapia inócua, né? Não é inócuo a gente prescrever antibiótico, em especial de amplo espectro. Então, A gente tem aqui esse triangulinho azul, que é um ponto de dúvida. Ninguém tem dúvida, na infecção bacteriana tem que dar antibiótico. Na sepse, o antibiótico é urgente.
Sepsis is an urgent antibiotic. There is no infection in the recurring trauma surgery does not need antibiotic. And since we have a doubt when we have patients that have an inflammation and we do not know, not for sure, if they have an infection, this goes into our topic today, perioperative infection. Why? Because our organism, it has the DAMPs and the PAMPs. And what are the PAMPs? These are the molecular patterns that our organism exhibits when there is a pathogen. The one there is an inflammatory response and release of cytokines, fever, leukocytosis, etc. This is the standard associated with pathogens, but we also have a DAMP, which is the damage associated molecular pattern to tissue damage. This tissue damage can be fluid trauma or trauma, burns, surgical procedures. The problem is that clinically it is difficult to differentiate the molecular standard associated to the pathogen versus the molecular pattern associated to tissue damage. So the response on an acute phase is a lot of the time it's common fever, leukocytosis, tachycardia. So SIRS, right? First, I have an idea, SIRS on surgical patients, it happens on half of the first day and more than 1/3 on the third day. So when we have trauma, the situation is a bit worse. Prevalence, accumulated prevalence of trauma on the first week post serious trauma is 90%, while the chance of a patient with serious trauma occurs the first day of the third week is around 50%. Well, it's very common for a surgical patient to have SIRS. So in a situation that we face, most that work with this daily. But the problem is not just a problem of specificity, it is an issue of sensitivity as well. So 1 every 8 patients serious sepsis, they do not fill up the SIRS criteria. So the patients that this study has 109,000 patients. So do the biomarkers solve the matter? Gaussian, sadly, no. PCR has a sensitivity of 75%, so it does not exclude infections, but the specificity is even worse, 67%. For patients with surgery, they can have an augmented PCR frequently without being an infection. So the specificity is of 81%. However, the randomized studies with procalcinin failed in showing benefits that would guide your therapy based on the procalcinin value. So procalcinin can help a little bit more, I suppose. Yes, I believe so. But on its own, also, sadly, is not enough to solve the matter. So this balance, since the 90s, a few authors have dedicated themselves to study with an inflamed surgical patient that has a systemic inflammation. What do? Give antibiotics to everybody, not give antibiotics to anybody. We wait. Focusing a bit more on today's subject. One of these authors is Professor Sawyer. Since the 90s, they've asked themselves if waiting for the confirmation of infection with a patient with fever is a bad move. In 2012, some research that had a big impact. What was done is that there was a pre-pause during a year. It was aggressive and gave antibiotics to every suspected infection, nosocomial infection. In another year, he only gave antibiotics infections confirmed or organic dysfunction. So what was a profile for this ICU? Surgical profile and trauma. That was today's subject. So this was controversial because in this research, we saw better results, a conservative behavior not to administer antibiotics patients when they're suspected infection and heat offense, yet waiting for an objective diagnosis if the patient has stable conditions is a better behavior those if there is no confirmed infection. So he questions this idea of isn't it better for everybody? Another study from Lancet that questions this here on the screen was published in 2018. It's a study with a very interesting timing. It proposes to give antibiotics in the ambulance and the European study when suspected infection, or wait for the patient to get to the hospital to be assessed by a doctor, and the doctor will define whether or not they will receive antibiotics. And we saw and there was no benefit in giving antibiotics while on the ambulance to patients at time zero. So the goal of our study was also to have some sort of contribution on the subject, on this blue triangle on the screen. Patients with inflammatory syndrome, post-operative syndrome that does not have a clear infection, because if they do, it's opposite, they'll need antibiotics. Also, they do not have an acute organic dysfunction. What do we do with these patients? The goal was to assess the association between the moment of administration, empiric administration, antibiotics, and then worsening of bodily function. What is our audience? The critical surgical patient without or acute organic dysfunction, non-septic, but they have a suspected mitochondrial infection without a clear focus. This was a retrospective study, observational study from the clinical hospital, trauma. So what was included in the study? Patients with a suspected nosocomial infection during their stay at the ICU. So how do we identify this? Patients that had a collection of a blood test with this suspicion. So the vigilance was excluded. It's very important to have this exclusion criteria. Septic patients or septic shock patients up to 24 hours, they would exclude them with a dynamic worsening, so the increase in adrenaline dosage was excluded. And there is a source of infection that is clear, excluded. Well, we considered that this criteria here indicates an immediate antibiotic application. So if the patient has septic shock, if they increase the use of vasopressor, they'll have a clear infection, then they'll need antibiotics. Yeah, that is the point of view. But if they don't have any of that, we can move on. And if there's other criteria that are a bit less important, and then we defined two groups. One group, we administered antibiotics within 24 hours of suspected infection. Another group, we did not use this in the first 24 hours. We may have administered this afterwards or not administered this. Just remembering, everybody, this is an observational study. The ones that define the administration of antibiotics is the doctor caring for the patient. This is an observational study. You have a zoomed infection when there was a clear focus, and when there was a confirmed infection, when there was a clear focus that there was a positive. What was the primary outcome for our study? Our question was, if I delay the empirical use of antibiotics, is my patient going to become septic? Well, they very likely become septic, so the outcome was the worsening organic dysfunction on the SOFA scale, or septic shock, or death within 14 days, one of three. So we did not demand a infection focus to close the primary outcome, because we understood that if we did this, we would go into subjectivity and we could contaminate the analysis. So our outcome, let's say that, yes, it's harsher. The change of the SOFA scale, or death, or shock. So we had the control of this unbalanced groups, the logistical regression, but based
Relacionado a cíclico, que é o que se sugere hoje em dia para modelos de inferência causal, tá bom?
it's causal. So here we have the chart I'm not going to go into more detail, but it's worth saying that this is a model that has been defended because it adds transparency to the model. Anybody reading the article, the publication, the paper can get the paper, check the chart, and see if they agree or do not agree with the proposed model. So the results here we had 2,000 or more interments during the period. 1,000 or so patients did not have a suspected nosocomial infection. They were not participated in the sample. They were of no interest. Was 750 patients had a suspected nosocomial infection. 410 were excluded. 300 because they had sepsis and shock. This is not our public. We are not speaking about sepsis or septic shock. Out of the 340 that remained, 210 had a conservative treatment, or that means that they did not take antibiotics the first day, and 130 had early antimicrobial treatment on the first day. So I could say here that the window of time is different than the one we studied with Kumar, which is hourly. We're talking about a day here. Why? Because this is not septic shock. Septic shock and sepsis is a window of hours. On stable patients, the window is not limited in such a manner. So which were the characteristics of our patients? Age, 44 years on average, young audience, mostly males. It's a trauma ICU, surgical emergency. More than 70% with trauma, the rest complemented with surgical patients, patients with few comorbidities, an average of 0 comorbidities. Here we need to know who we're talking about in this study. Despite a relatively low age, few comorbidities, these were serious patients. More than half were intubated, 57%, 63% were intubated. So they were more than 110 of frequency, they were tachycardic, they had fever, leukocytosis, high PCR, and 20% were using vasopressors. All right. So these were serious cases for these patients. So what was the outcome of the study? The primary outcome happened in 56% of the empirical therapy group and 40% on the conservative group. So the early empirical therapy group had a higher progression towards organic dysfunction. Now, of course, this needs to be adjusted, but talking about which organic dysfunctions were worse here, there's light orange here. This is the conservative group. Dark gray is the early treatment group. So we can see that the main, each of these dots is a page. We can see that the ones that progress the most over time, the initial SOFA and the peak SOFA was cardiological dysfunction, which is vasopressor, and renal dysfunction. Both groups had a SOFA progression, but the progression was higher on the early treatment group. But this is the group, this is the raw data. We foresaw that to balance out the groups, we would need a multivariate analysis because we're proposing some sort of causal inference on observational studies through the cyclic chart be directed and logistical regression on a multivariate analysis. When we move towards primary multivariate analysis, we can see that the GTEP, which is the early treatment group, had no association with primary outcomes. And it's interesting to us to know that there was an association. Sure, the lead cause was the presence of a presumed infection. So the patient afterwards was in fact infected. This is the lead cause of organic dysfunction. Another interesting factor here is sustained tachycardia. Patients with sustained with above 90, constantly above 90 tachycardia, they also had a risk factor. Sensitivity analysis, they confirmed what we're talking about. So the group where the patient was allocated to, they had no correlation with primary outcomes, be it on the primary analysis as well as sensitivity analysis. So on sub-analysis, will happen only on patients with a confirmed culture, confirmed infections. So we have a curious piece of data here, which is that the time up till the appropriate antibiotic therapy was associated to the primary outcome. So each day that the patient with a confirmed infection through culture delayed their antibiotics, there was a primary association outcome. The allocated group did not have this. We're going to go back to this later. So, discussion. First thing regarding the design of the study, there is an ethical difficulty on randomized studies with this subject because you're going to tell doctors, look, this patient, if they have a suspected infection, you're not going to give them antibiotics. And then the other patient, you will. So there is an ethical issue here. So this is the reason why we had an observational study. The outcome was agreed upon as a combined outcome. But we thought it was a good way to reach your conclusion because at the end of the day is if I don't apply early antibiotics, will I have more sepsis further on down the line? As I said at the beginning, we decided not to place infection as a this obligatory on primary outcomes because we understood that this would add subjectivity to the primary outcomes. Regarding statistical analysis, we have the chart that is cyclical. I believe that it is the standard that must be utilized on most cases or observational studies. Causal inference, the cyclical analysis chart will tell us which variables must be applied in a multivariate analysis and enhance transparency. So when we're using a multivariate analysis, many variables that are chosen, it's not so transparent. And this chart helped a lot. So I reiterate that for us, we had the regression and the result was the same. It doesn't change our conclusion, okay? So very interesting case is that there's no disbalance among the groups. The ones that took the early antibiotics, even the patients that were intubated, even with vasopressors, the ones that had an inflammatory difference, but not in gravity. It called our attention that both groups, when they had this inflammatory status, they had an elevated incidence and worsening of the SOFA. 40% on control group and 56% of GTAP group. The main drivers for this worsening of the SOFA was renal and hemodynamic, so blood and kidneys. So when we go to the multivariate analysis, there was no association between the early treatment and early outcomes. So it's clear for us that the main determinant of the primary outcome was the presumed infection. This is no surprise, but it's what matters is whether the patient has an infection. The results maintain themselves in our sensitivity analysis to show that we have a good internal validity. Now, this is a piece of data that we need to sort of hit our heads against a little bit. There was an association between delayed administration of antibiotics on confirmed infection patients and the primary outcomes. So if you delay application of antibiotics on patients that are in fact infected, this is associated with worse outcomes. So how do we get these two pieces of information that are apparently contradictory? There's two hypotheses. One of them is that despite our attempts, we did not manage to perfectly adjust the seriousness of the sample, the gravity. I believe that this is unlikely because we had very consistent results when it comes to sensitivity analysis, but it is a possibility due to the results of the study. But what I believe happened is that the beneficial effect of antibiotics, it does not extend when you give it to everybody, to those that are infected and those not infected. Why? Because individuals that are not infected
Isso
and
contrabalanceia.
there's a potential for a worsening outcome. This counterbalances the benefits of patients that are infected. So here we have the chart of how we imagine things happen. When you get everybody up there and you just give everybody antibiotics, maybe the total effect will be neutral. We know. Why? Because we have benefits for people that have an particular infection, while the potential worsening for people that don't have an infection. So the consequence of our hypothesis is that the priority is to get a correct diagnosis. We need to be right when it comes to our diagnosis. So we have an idea how problematic this is, what a difficult matter this is. This European studies got patients with sepsis and septic shocks to the ICU and saw that 40% of these patients did not have a likely infection. So they were interned with a septic shock diagnosis, and in a rigorous analysis, most likely it was an alternative diagnosis. But that's not the worst part of it. The worst part of it is that the patients that went into the ICU, they were said, okay, they're septic, but it's not sepsis. It's even worse mortality rate because not treating the root cause can be lung embolism, some kind of central neoplasia. If you get diagnosis wrong, that's a serious problem. This is an interesting study from 2009 showing that even if the patient is infected, if you get it wrong, if you get the place of the infection wrong, or if you don't know where they're infected, I think it's much worse, even if we adjust the mortality rate. If you get it wrong or you don't know where they're infected, 24.8% versus 13 when you have the right place. When you adjust for the gravity, but quick sofa, the difference is more subtle, but when you go to PSM score, the difference is the same. This can be explained. Okay, if the patient has meningitis and you prescribe wrong medicine, it's not going to work. It's not going to do anything. So I'm giving you an example. If you think it's pneumonia and it's acute abdomen that must be operated on, that's going to be bad. They're going to get their surgery delayed, be it a debridement or any other surgery, whatever it is. You miss the right diagnosis, it's going to be a serious impact for the patient. So here, I have a vision that is very, very right for Tobin, very famous doctor in the ICU. I think we had the TOBI index, which is the quick respiratory utilized to the application of a successful application, and he put down his 40-year vision. And medicine is this vision is the following. He jokes around a little bit. That's three most important things in clinical medicine: diagnosis, diagnosis, and diagnostics. As a joke, why? So it's syllogism and logic. When the major premise is wrong, if the major premise is wrong, the deductions are irrelevant. So if we get the diagnosis wrong, then maybe our whole treatment could be worse for the patient. Or be useless. In the best case scenarios, it'd be useless. So, and he says that we must be right in our diagnosis. That's what he's saying. Let's talk a bit about the limitations of the study. Retrospective observational design, unicentric, that is, we had no standardized criteria for infection for suspected or to use start of a use of antibiotics. That was up to the doctors that were caring for the patients. Our sample had a specific profile. Young patients, few comorbidities. We need to be careful when we extrapolate this data. So based on the literature revision, here we have a suggestion to guide our reasoning in the situation. If I have a patient that we suspect of being infected, but without a clear focus, the first thing I'll do is I'll research the infection focus and alternative diagnosis. Here I have three scenarios. If it's clear for me that the patient has the focus at the focal point, it must be treated ASAP. We cannot delay antibiotics for patients that clearly have an infection or an obvious focus. Our study showed this as well. If there is a clear focal point, the patient must have an immediate treatment. That's clear. If there is no clear focus, but they have a septic shock or acute organic dysfunction, we need urgent antibiotic, ideally during the first hour. I have no doubts.
Ou disfunção orgânica aguda precisa de antibiótico em caráter de urgência.
Must receive this urgently, a clearly affected patient. But we have another situation that is not uncommon. It is not uncommon, which is patients that have no focus, that is not clear, they have no focus, they have inflammation, they have fever, leukocytosis, whatever it is, they are stable. No focus, no acute organic function. In this case, a suggestion, especially for patients that were not neutropenic, etc., we need to maintain these antibiotics in research. This is a suggestion how we think of the three situations: sepsis, septic shock, urgent treatment, very likely infection, immediate antibiotics, and stable patients without a clear focus, without organic dysfunction, low risk of evolution, where sepsis must be researched. So, in conclusion of the study, the absence of the administration of antimicrobial therapy in up to 24 hours of suspected infection and critical surgical stable patients without a clear source of infection was not associated to a higher incidence of purgatory sepsis, septic shock, or death in 14 days. As we said during the doctorate now, I believe that this is very much related to the subject matter, and we cited Tubman, speaking about syllogisms and deductions. Here I cite a phrase from Aristotle: excess and lack destroy perfection. Excessive care and lack of care destroy perfection. In this case, we're talking about the excess of antibiotics for everybody lives to still a bad outcome, but a lack of antibiotics is awful as well. So we need to hit the target. We need to get it right. We need to always be on the patient side, always be attentive, always need to be careful, and we need to seek out the diagnosis as best we can. Everybody, I'm very thankful for the invitation once again. It's an honor to be speaking about this. I love the subject, and here I am, available to discussions, questions, or doubts. Thank you very much. I wanted to congratulate Estevão for his great presentation. This is a very complex subject. A few comments. Bacteria, as any living being, despite being single-celled, it is alive. It has a genetic equipment on some part, codifies defenses. It will try to protect itself. There are studies that show that material get from permafrost and the Bering Strait that are about 30,000 years of age show that genetic material of bacteria that is present there codified a few resistance standards for a time. For our current medicines, 30,000 years ago, before antibiotics, and the WHO sees that in the future, bacteria, multi-resistant bacteria causing infections will be a issue bringing us that as big as cancer or cardiovascular diseases. I believe that this matter that is being discussed today regarding BJAN is a very interesting subject, which affects us in a very intense manner. I wanted to open for the audience, for everybody that is watching. You may ask questions, and so we can have a sort of debate. Whatever you place on the Q&A or the chat, we will read it to Estevão and we will hear his opinion. But start this whole discussion, I wanted to propose the first question for Estevão. Estevão, but this is a retrospective study, right? It's very interesting. It's a possible analysis of reality. It's randomized, as you said, from a research point of view. this scenario is something that can be considered anti-ethical. Maybe we can increase the patient's risk, but what is the importance that you give? How can you effectively measure the clinical outlook when it comes to applying antibiotics or not? How do we deal with this situation? Look, this study was very interesting.
Proporção de
We saw
pacientes
the proportion of patients
tinha infecções de
that
fato
had,
a
in fact,
posteriori do grupo
infections
que tomou
afterwards, or the group that
antibiótico
took early antibiotics,
comparado ao grupo que aguardou.
when
O
compared to the
grupo
group
que
that
tomou
waited.
antibiótico
The group
precoce
that
tinha
took
uma
early
taxa
antibiotics
quase o
had a
dobro,
rate which
quase o
was
dobro
almost
do grupo que não
double
tomou.
of the group
Não
that
era o
did
dobro,
not
um pouco
take.
menos, né?
It was
Mas
not
assim,
double, it
muito menor.
was a bit less, but was much
Então,
higher.
isso sinalizou para a gente o
So
seguinte:
this
quando o médico,
signaled to us that
pelo menos
when
naquele cenário que a gente
doctor, at
estudou, né,
least that scenario that we're
tinha a
studying,
convicção
had
de que
the
era uma
conviction
infecção,
that it was an
ele
infection,
acertou em grande parte dos casos.
and he got it right
Quando o
most of
médico
the cases.
achou
But
que não
the
era
doctor thought
infecção,
it was
a
non-infection.
chance de infecção
The
caía
chance
muito.
of infection went
Mas
way
vale
down.
ressaltar que
But it's
nesse
worth mentioning
cenário
that
de estudo
this
nosso
scenario,
aqui,
that the
vocês
study
notam
of
lá
this
no
ICU, you
flowchart,
can see that in the
a
flow
maior
chart,
parte dos pacientes
most of the
foi no grupo
and the group
conservador,
was
né?
the conservative
Então,
group.
era uma uptake muitas
So,
vezes com a
so
conduta
ICU
conservadora. Agora, quando
that
o médico
adapted
achava que
a
estava
conservative
infectado,
attitude. But what the
a chance foi muito
doctor
grande. Eu
thought
acho que o
that were
feeling do
affected
médico,
was a big chance of
o
them. I
feeling
think that the
é uma
doctor's
coisa
feeling
difícil de
is
mensurar,
difficult
muito
to measure.
intangível,
It is not
mas
something that
muito
is
importante
quantifiable easily, but it's
nessa
very
definição de
important
infecção. Esse
when it comes to
estudo ela
defining
reforçou.
infections.
Eu
This is
acho
what the
que a
study reports.
gente, todo mundo, todos nós
I think
médicos,
that all of
a
us
gente,
doctors,
tem hora
we,
que a gente fala, cara,
well,
esse
there are
paciente
times
está
when we think,
infectado.
oh,
E tem
okay,
outras
well, this
horas que a
patient
gente
is
está na
infected, and there's times
dúvida,
when
né?
we
Eu
are
acho que esse
having doubts.
estudo, a
So
mensagem
I
assim,
think that this study
é o caso que a gente está na dúvida.
is the case that
Esse
we
estudo é
have our
aquele caso que a
doubts.
gente não tem certeza. A gente tá na dúvida do paciente está
So we
bem.
have our doubts that the
Porque
patient is okay.
se o médico
Because if
achou
the
que era
doctor,
achou a pneumonia,
if
achou
they had they thought it was pneumonia, if they thought it was something on the
esse
abdomen,
paciente
on
acho
the
que não é
legs,
para perder tempo.
patient, I think they shouldn't be wasting time either. You know, these discussions are very important. The audience, I think that well, the Q&A is open. Please feel free to add your questions. But meantime, these discussions that we're having very relevant to participation during the perioperatory period. And so you said that was something very interesting. All antibiotics have a harmful effect. We know that. Literature makes it very clear that, as I said at the start, the mechanism bacterial that or bacteria, you've talked about bacteria as living beings, so maybe in a million years, maybe bacteria has become another type of life form. They evolve into another sort of organism that is more differentiated. We know that whenever we apply antibiotics of any sort, we're going to induce bacterial resistance, and this can change effectively the ecology of a determined unit in the health services. So I ask you this scenario, maybe it will be a bit this talking about what's worth pondering. How do you see the idea of protecting the system of for multi-resistant bacteria? The more intense, the stronger the antibiotics. For instance, the higher it is you have the effect of generating multi-resistant strains versus the treatment of the patient. How do you see this scenario for therapeutic conflict? You want to conserve the ICU, but you want to treat the patient. You want to conserve the ICU. We have some degree of suspicion. Oh, great. I think that one of the messages that literature was pointing out for some time,
Aliás, né, como tudo na medicina, não
antibiotics
é
is
inócuo.
everything in medicine is not innocuous. It's something that we must
Não é inócuo
comment
para
on.
o
It is
paciente
not
utilizar.
innocuous for the patient
Aliás, né,
prescription.
soro também não é inócuo. As nossas
Serum
condutas
is not
médicas
innocuous.
não
Our
são
medical
inócuas,
behavior
né, para
is
o
not
paciente.
innocuous for a
A gente
patient.
tem que pesar se elas
We
estão
must
fazendo bem
think about whether or
mais
not
do que
they are
mal.
doing more harm than good.
Então esse é o peso.
And
Eu acho que a
that's
gente
that's
tem
the
um
idea.
peso
I think that
ótimo,
we have
mas a
a
gente tem um
good point. I think that we have a point
beneficia o paciente
where benefit the patient
prejudica a
did
ecologia
not
da UTI,
harm
né?
the ICU
Eu acho que a
ecology.
gente,
I think
chegando no
that
diagnóstico do
getting
paciente,
to
a
the
gente
patient
conseguir
diagnosis of the
estabelecer uma
patient, and
melhor
where you can
identificação
establish
possível
with a higher
do
accuracy the
essa
diagnosis as
complexo
an
do problema
infection.
que o
It
paciente
is
tem,
bacteria. Is
tem
it
que
infection?
fazer
Is it a
com
bacterial
que
infection
a
that the patient
probabilidade
has?
de infecção é baixa,
The
não precisa
likelihood
de
of
antibiótico.
infection is
Eu
low.
acho que
They
esse
do not need
é
antibiotics. I
o
think
primeiro diagnóstico.
that's the way
Sobre os
to
efeitos
get the
que a gente tem
diagnosis
na
right.
ecologia, não
Regarding the
só
effects we have on the ecology of not just the
mas
ICUs, but
os efeitos são muito grandes,
worldwide, the
né?
effects are
A
big.
gente tá
You
aí
know,
batendo no estado
we
de São
are
Paulo, a última vez que
basically
eu
in the state of
conversei,
São
o
Paulo,
Klebsiella
as we
bate
know, Klebsiella is
50%,
50%,
Klebsiella quase
Klebsiella, almost
resistente a
50%
carbapenem,
resistant to carbaphenemic.
quando a gente pega o estado. Então é uma coisa assim
So
assustadora.
it's
Agora,
scary, it's
eu não
alarming.
mostrei aqui, porque senão eu ficava
And I do
falando
not
demais,
show
né?
this
Quando
here
o
because
paciente
maybe
tem
you'll
um
become too expensive,
carbapatêmico
but
zero
when a
vírgula
patient
zero
has
oito,
carbonemic,
a chance dele ser
the
colonizado
chance
por
of there being
KBC aumenta de 4
colonized
a
by a
5
KBC
vezes.
goes from 4 to 5
Então,
times higher.
quando a gente
So
prescreve esses
when we
remédios, a
prescribe
gente tem que
these
pesar muito,
medications,
pensar
we
muito se a
need
gente
to
está fazendo
really
o
think about
melhor,
whether or not we're
né?
doing the
Ou se a
best,
gente
or
está
if we're
tentando, se a
we
gente
have
fala,
our
não,
doubts, if
vamos
we're
tentar achar a
having
cura,
doubts,
vamos
let's
tentar
get rid
achar
of
a
these
cura,
doubts. Let's
né?
try to get rid of our
Claro,
doubts.
tirando as
Let's see,
situações de urgência que a
think,
gente já descreveu aqui,
removing the urgent
né?
situations we described here
Eu
already.
acho que a gente tem um ponto
I
ótimo,
think
e
that
o
we
ponto
have a
ótimo
good
depende do diagnóstico
point,
novamente,
which depends
do
on the
diagnóstico
diagnosis
da
of
melhor forma
the
possível.
patient. It was the best diagnosis possible. So here's a piece of info. I lost it for a second. Recently, it's a discussion regarding multi-resistant bacteria here in the state of São Paulo. I'm going to tell you the number according to CZE, which is the Epidemiological Vigilance Center. 58% of recuperated on a culture resistant carbaphenemics. Citerbacter balmani have resistance of 87%. So this is it's a problem that is already here. It's here now, and we have reality increase in mortality is very important.
Tá pior do que eu
Oh,
pensei.
it's worse than I thought. Last time I saw it was 50-58. That's frightening. That's 2021. So I saw that's a scary number. If you think about it, imagine you prescribe norepinemic for a patient thinking that you're fine, that you're getting it done. So this is scary. It's a scaled curve. Okay, well, okay, I think this scenario is actually worse. Imagine that our colleague was this intraoperative situation, anesthesiologist like me, like Andre. Yeah, have a scenario like this, and it seems like the patient has inflammation there, these drugs, they have fever. They have an organic dysfunction, intraoperative, but it's a surgery, it's a large-scale surgery. And it is, see this guy, he isn't exactly what you saw in your study. So how do you deal with this? So the super surgery patient that will have to go through esophagus surgery, and during the surgery present something regarding fever or something, but maybe not because they have they see in the operation, but you start becoming hypotension and adrenaline. How would you deal with a scenario like this? Because I think that the context of anesthesiology and intraoperative, it's a bit more complex. How do you see this? How do you think about this?
Perfeito. Eu acho que tem dois momentos, né? O momento do intra e do
When it comes to the
pós-operatório
interim,
imediato, que a gente
immediate
tem que sempre se
post-operatory
basear
situation, we need to base
se a gente vai
ourselves.
tomar antibiótico
Patients will
profilático,
be
como
taking
a
prophylactic
cirurgia, né,
antibiotics routine.
pós-cirurgia, a gente tem que se basear na parte se a
That
cirurgia
needs to
vai
be based
contaminada,
on the
daí
contaminated surgery.
se existiu
If there is
alguma infecção.
some form of
Se
infection,
existiu, a gente vai tratar com antibiótico
if there
profilático,
is,
que é o
we will
antibiótico
treat for antibiotic therapy. If
depois
not,
disso, né? Então
prophylactic
vamos dizer assim,
antibiotics, and
passado esse
afterwards,
período,
well,
que eu acho que
after this
começa uma
period of
situação muito
time, we start a
interessante
very important
e muita
discussion.
gente desconhece. O paciente,
A lot of people
a
don't know
cinética,
about this.
por
Well, the
exemplo,
patient
do PCR,
or the
o
PCR,
PCR após
like the
uma agressão
PCR,
sistêmica,
after
após uma
systematic
infecção ou após uma
infection,
cirurgia,
after a surgery, on average,
ele melhora
on
após
average,
48
it
a
improves
72
after
horas.
48 to
Então, ele
72
não
hours.
melhora
So
após
it
24
not
horas.
improve after
É uma
24
coisa que eu vejo
hours.
muita
It's something that I see
nuance,
a
né?
lot on
Muita
average.
confusão. Da mesma
a lot of confusion because in the same way it serves the inflammatory systemic response does not improve quickly, does not improve in 48 hours. It improves afterwards. So in this initial phase, we're going to have a large-scale inflammation. Very likely will be inflammatory if the surgery is not contaminated. The inflammatory markers can actually go up. So what helps a bit is the organic dysfunction. The organic dysfunction after surgery are worsening. If you add to them, we need to start thinking about something else. If organic dysfunction can start to improve, especially hemodynamic, because renal actually improves slightly sometimes. So we're on a different path. What I wanted to stay on that hook of yours that to me, because a lot of the time there's a concept that SIRS or PCR will improve in 24 hours or 48 hours. No, on average, that's not the average. The average is afterwards. I wanted to ask you, there's a question. Thank you for Celio. It's good to see you here in the audience. He sent the same question that was a bit more simplified because I did not understand the question. Forgive me, but could you maybe rewrite your question? So while you rewrite the question, Celio, I want to ask you regarding the methodology, which I think maybe is worse, which is there's an outcome, a primary outcome, post outcome of the outcomes. It's always something that is a bit more complex because what's interesting for me regarding this, what is the most frequent event? Was it sepsis, septic shock, or death? What did you observe more frequently so we will see what happened? The most frequent one is sepsis, which is the worsening of organic dysfunction. By far, that was the most frequent one for death, more frequent than death and septic shock. And it was actually surprising that our patient, a lot of the time they got worse, 15% of the time they worsened. So it doesn't mean that they passed away, but their dysfunction got worse when the patient was actually having inflammation. So the outcome, the composed outcome, having inflammation is a bit difficult. They have their complications, but we saw a lot about how to do things differently. And if the patient passes away and does not increase the sulfa, it must count as a worsening as well. I mean, that death appears as a competitor of the patient. And here's some details for sulfa. Yeah, they already have a cardiovascular dysfunction, or there's no way for them to get worse than that. They go to the definition of a septic shock. So there wasn't a lot that you could do differently for the question that we asked ourselves was the worsening of organic dysfunctions. I wanted to pass on to Andre, see if there's any questions. I have a question, a quick question. Sorry about interrupting. Congrats, Estevão, excellent presentation, great discussion regarding the subject matter. Just to add what Luis already added to my question regarding that, regarding the multi-resistant bacteria, more and more we get patients that are colonized, already colonized, were in current recently released that were influenced. More and more we get multiple intern patients actual intensive therapy, and a lot of them colonized for us to have a large-scale surgery that would involve this that already an inflammatory response intraoperative. So these cases that are more frequent, what is the recommendation? Go to antibiotics of a high spectrum antibiotics, thinking about covering this bacteria that is only being colonized at a time, months later, or do we move towards intermediate therapy? A lot of the time we've asked these cases for the assessment of the hospital infection, but a lot of time see people asking what to use, and a lot of time they have not recommended antimicrobial that cover this bacteria. So that's my doubt. Is there some sort of commendation, or is there no evidence regarding this? Oh, that's a good question. I think that this confusion is generalized and well, it's general. I think that nobody knows exactly what to do. What because the patient is in the ICU.
Vou elaborar alguns cenários, né? Tá na
Getting
UTI,
a scenario,
não tem uma
they're in the
conexão
ICU,
interna, e um
but
paciente
they
com
don't have a
longa
conversation. They have several approaches.
internação longa,
Long
não se
internment,
recomenda, quase nunca vi
not
uma
recommended,
recuperação
almost
imediata.
never
Eu
to
nunca li e
recommendation.
vai ao esquema usual. Então, esse paciente recebe o esquema usual.
This patient has a usual idea. They're not not colonized.
Colonizado é uma outra história.
Patients that are colonized is a different story.
Conheço evidências sólidas
I do
sobre o
not
tema.
know
Eu acho que se o
any
paciente
solid
teve
evidence
uma
regarding the subject.
infecção
I think the patient had a recent infection,
ou se
create,
é uma cirurgia
or
com
if there is
altíssimo
some
ou
surgery
muito
with a
alto
very
risco
high
de
or very
contaminação,
high
eu
risk of
penso que vale a pena
contamination,
cobrir.
I think it's worth
Caso
covering.
contrário, não.
If
Então,
not,
assim,
no.
peso muito risco-benefício e
So
muito, porque
we really
se
need to
fosse
weigh
só essa
risks and benefits
colonização,
because if
veja bem,
it's just
colonização de
colonization,
swab rectal.
colonization
Colonização
or
de swab
rectal
rectal e vai
swap
operar,
colonization, and you're gonna
sei lá,
operate,
uma
I don't
cirurgia
know,
ortopédica,
an
alguma coisa que não
orthopedic
tem nada a ver.
surgery,
Eu
something
acho
that is
que
not
isso
related. I don't
pode
think you
ter,
need to.
não precisa nesse caso.
I don't
Agora
think you
não,
need to
ó,
in
o
this case.
paciente teve
Now,
uma
if the
infecção
patient had
recente,
a recent infection,
uma infecção recente, uma
a
bacteremia
say a
cresce
bacteremia,
aspas, e vai trocar a
this
prótese do
they will
joelho.
go
Tô chutando
towards
aqui, tô
go
dando um exemplo.
change
Aí
your
precisa.
knee
Nesse
prosthetic,
caso
then
precisa.
they'll need
Então
it.
eu acho que por isso a
So
inclusão
I think
tem que
that's
ter uma
the
certa
conclusion. You
maleabilidade.
need to have a certain flexibility.
Eu vou fazer um comentário aqui,
I'm gonna
aproveitando o gancho do
come
André e
here
do Estevão,
on
que
what
assim,
Andres
eu
and
tenho um
Stebbins
pensamento
thinking
guia.
about,
Você está
because
falando
we
de
talked
4
about this.
horas,
We're
mas eu
talking
vi no
about
ambiente, o meu
hours, but
problema
I thought my
é desviado
my
para
issue
de KPC.
is the
Esses dias a gente
KBC
teve um
production.
MBM, que é
The
um
problem is that there's an NPM,
metalobeta-lactamase, que é um troço ainda mais
so
complicado.
it's
E uma das
a bit
discussões
more
que a gente
complication. One of
tem
the
tido com
discussion
o PET, com a
that
turma, é o
we've
seguinte:
had
se o cara está
is that
colonizado
if
com uma bactéria
colonized with
multiresistente
a
em cima da
multi-resistant
gente,
bacteria in
talvez
this
a gente tenha
scenario,
que dar um antibiótico
maybe
inicial na
we'll have
suspeita
to
do
apply
André,
the initial antibiotics,
pensando em tratar
thinking
essa bactéria
about
multiresistente
treating
que
this
coloniza o
multi-resistant
paciente.
bacteria that is
E
colonized
isso
in the patient.
aconteceu esses dias aqui com a gente.
And this happened these
Eu
days with
entendo
us.
a dúvida do André, eu acho que esse é um problema seríssimo.
I think
Dado
that
certo que
this is a
isso
huge
tem uma
issue.
frequência que
It's
acontece.
sort of, it's frustrating because this
Deixa
happens
eu
frequently.
fazer uma pergunta aqui mandada pelo
Make a
Celinho.
question sent
Ele
by
mandou,
Celio.
eu dei uma
He
arrumada
sent it.
aqui e vou ler para você, Bassi.
I'm going to read it to
É
you.
possível que
Is
fragmentos
it possible that
de
fragments
bactérias
from
que
bacteria
tiveram
that
contato com
had
antibióticos
contact with
e
antibiotics at
essa
hospital
informação que induz a
take this
reação
information that induces
das
resistance
bactérias vivinas,
to environmental
mesmo que
bacteria,
essas não tenham
even
tido
if this had
contato com
not
antibióticos?
had contact with antibiotics?
Ou seja,
Deixa eu ver
você
se eu
acha que
entendi
pode
a
ter
pergunta.
Let me see if I understood.
transmissão? Uma
Well, I was talking about
bactéria,
transmission of a bacteria.
a
Let's
bactéria,
say the bacteria
o cara tomou
the guy took.
eu entendo a questão que ele
As I
fala, que é o seguinte,
understand what he's
o
saying,
cara
which
tomou
is,
antibiótico
let's say the guy
inicial
took antibiotics to
para
the hospital
determinada bactéria,
to
que
treat a
quando dava
determined
reação
bacteria.
aparecia uma bactéria multiresistente. Será que
And then
a
there is a
própria bactéria, ainda
multi-resistant
mesmo
bacteria.
depois que ele
Will this
cessar o
bacteria, even
antibiótico
after
persistir,
stopping
esse cara
the
encostar,
antibiotic use, will he persist, or
essa
if the guy
bactéria dele com outra
goes up
localmente
somewhere else,
ou
will he
por
transmit
qualquer outro
this,
mecanismo
let's say,
intestinal?
any sort of resistance waters?
Tem gene de transmissão, sim, né?
There are
Gene
transmission
medial,
genes. Yeah, there's
isso
plasmidial
está
genes.
bem descrito. Tem,
This is well
principalmente
described.
através de plasmídio, que induz resistência em outras bactérias não resistentes. E,
And this moves on to
infelizmente, a
other
resistência
resistant
pode ser
bacteria.
contagiosa.
Sadly,
Entre aspas.
resistance can
Eu
be
não tenho
contagious,
esse
so to
dado,
speak.
É verdade, é verdade.
mas a resistência pode ser contagiosa, sim.
So it can be contagious. It can, in fact, be contagious. But this discussion is very important because discussion is the real one. Because we're discussing a small slice of the issue, because a lot of the antibiotics in the world being used are not in medicine to treat patients or in veterinary disease, veterinary medicine to treat your pets. So use antibiotics so that the pets don't develop, but they end up. So there's a C study that shows around 10% of patients at the emergency service. I think this is a discussion that is going to go far. I think it's almost trying to finish, right? It's an hour discussion. Everybody has sure has several questions, but I would like to once again thank you for the opportunity to moderate this opportunity, Andre, Mel, Bassi, for being with us. Pass the word to Andre for finishing statements. Perfect. Luis, Estevão, great presentation. I think it was a big chance, especially for anesthesiologists, not just for those working on intensive therapy. I think it's important to know about this and implement this. And Mel that is here, we will be actually recording the podcast soon, which will approach specifically the subject of multi-resistant bacteria. And of course, Johnny, Andre Johnny, Luis Marcelo, those colleagues from more specifically with the subject, especially therapy. And this podcast for us and this supplementary that we can discuss today. And thank you for your attention, and we will see you. Thank you very much. Thank you, everyone.